Institute, and it is April 1st, 2021, and we're here performing a Deuk laser disc repair on a patient with chronic back pain and leg symptoms. And we had an issue with our live feed, so we just are now picking up. We've just started 5 minutes ago. We're getting our fluoro pictures, and our patient is still awake, and he's laying here on the table doing a great job. You comfortable? Huh? Yeah. He said he's doing fantastic. He feels like he's at a Club Med vacation. All right. Huh? All right. You're having some pain. The reason he's having pain, folks, he's obviously awake. We need our patients awake for the lumbar and thoracic laser surgeries, because I need their help for two things. Specifically, one is navigating into the disc that needs to be repaired, and the other is testing the disc that needs to be repaired. We are now at L5S1. L5S1 is the hardest disc to access in the lumbar spine anatomically because of the iliac crest. You doing all right? Yeah, is still feeling it? I couldn't understand them. Is that a yes or a no? Maybe so. All right. Well, you are watching a live stream today from Deuk Spine Institute. If you're watching on April 1st, we broadcast our surgeries around the world for everyone to see. And we do this for educational purposes, so the world can learn that there is state-of-the-art advanced spine surgery techniques. They're not available everywhere. Endoscopic spine surgery is, in my opinion, I read a number the other day. I've been quoting that there are 1 million fusions done a year in the United States, and I read the other day a newer number. Apparently the number's gone up. Spinal fusions are now at 1.7 million a year. And this surgery you're watching right now is the surgery that will replace spinal fusions in the future. The problem is that surgeons don't know how to do the surgery, except for me. I'm the one who pioneered it and created it. And unfortunately, there's really not a lot of interest, mostly because people don't know about it, right? Look at the nuclear bomb. The United States developed it. There wasn't much interest in it until they found out about it when it went off in Hiroshima and Nagasaki. And then the whole world became very interested in it once they were aware of its potential. Totally against violence and war, but this procedure is just like that. It's a technology that's so advanced and so, I hate to say the nuclear bomb is beneficial, but it stopped the war and stopped many lives from being lost. So in a way it was beneficial. This surgery will cause the demise of only one thing. Anybody know what that is? Huh? Good, that's a good guess. It will stop, this surgery will create the demise of open back surgery and open neck surgery. It'll, what is the word? Bring forth, huh? Make obsolete spinal fusions. There's the right word. This surgery will make obsolete spinal fusions, except for about 1% of the patients that currently get it. So instead of there being 1.6 million, and the number is going up every year, folks, 1.6 million spinal fusions done every year in the United States, the number will go down, and there will be about 1 to 2% of those fusions will be done in the future. Once every surgeon, spine surgeon, knows how to do the surgery. Once they're able to do this surgery, they know how to do it, and they have the equipment to do it. Once they have the training and the equipment to do this surgery, spinal fusions will literally disappear. There will only be a few places in the country that do it, because it won't be necessary the rest of the time. So if you're watching this surgery, you're watching literally the birth of a new technology. It's funny to say that because I've been doing this for 16 years, been broadcasting it for about 7 or 8 years now, every single one of these surgeries, and yet not a lot of people know about it. So we're trying to raise awareness that you don't have to have a spinal fusion, number one. But number two, Shant, you can get your back pain cured with this surgery. It's the only surgery in the world that cures back pain. Does it do it 100% of the time? No, Shant. Probably our average is now 98% elimination of back pain. I know it's a bit uncomfortable, Shant. I apologize. Our patient is awake, for those of you wondering, Shant. And the reason our patient's awake is I need their help for the surgery. Shant. You've heard of awake brain surgery. Probably, I imagine you have. AP. Awake brain surgery is done awake because the surgeon needs the help of the patient to perform the surgery to its very best ability. And what that means is, that's perfect, back to a lateral. What that means, for example, in awake brain surgery, since I'm a brain surgeon, I get to talk about brain surgery. What it really means, simply put, is that you need the patient to tell you if you're getting too close to parts of the brain that are necessary as you're taking out a tumor or an epileptic focus. Shot? All right, I don't know if we're too low. Shot, I think we're good, actually. Are you comfortable? He's okay. And where is that blood pressure? Is that 111? Nice job. See, I knew you could do it. That's
We have
perfect.
a question from the audience.
We have a question from the audience, but I'm not going to take it just yet. I want to take a step back for those of you who've never seen this surgery done before. What you're watching is a type of endoscopic spine surgery. And just like the stealth bomber is a type of an airplane, it's not like any other airplane you've ever seen. It's a very special plane. It has very special capabilities. It's able to deliver a result that no other plane in the world can do. This surgery is the same way. The basic technique of the surgery is endoscopic spine surgery. However, what I do once I'm in the disc that's herniated and causing symptoms is different than any other surgeon in the world. And that difference is what I do specifically with the annular tear. I'm the only surgeon that treats annular tears because annular tears are the source of the back pain. All right, so all of this is being done with a 7mm incision. Now, it's getting a little crowded, and I'm going to take the question and answer it in a moment, but I want to just talk for a moment about why we're really here. Our patient, Shot, is having back pain and leg symptoms. And what I mean by leg symptoms, there are really 4 types of symptoms people have in their legs: weakness, numbness, tingling. Shot? It's a little lower than I want to be. Weakness, numbness, tingling, and pain. Weakness, numbness, tingling, and pain. Those are the 4. It's okay, you're doing fine. Those are the 4 possible symptoms that can happen. Where do you feel that? Huh? In your back? Okay. You're fine. Just relax. I'm going to make it better. Shot? Shot? So I'm navigating to the last disc. Shot? AP? But what we're treating here is a patient with back pain and leg symptoms. His leg symptoms and back pain are coming from a herniated disc. You've all heard the word herniated disc, bulging disc. Well, that's what he's got. And that herniated / bulging disc is causing his problems. All right, let's go back to a lateral. Can I see the lateral view? Do you have it still? All right, just go back to a lateral. Save the AP. So he actually has 3 herniated discs in his back that are causing his back pain and his leg symptoms. 3 herniated discs. And those 3 herniated discs are L34, L45, L5S1. So our job today is to go in there and fix those 3 herniated discs, okay? And by fixing them, my goal is to get rid of his back pain permanently for the rest of his life. Shot? And I believe I can do that by repairing his discs. He believes I could do that. That's why he's here. He's seen the results of the surgery. He knows it works. And that's why he's here having this surgery done. Shot? Are you feeling any discomfort? Where? Where? I can't hear him. By your spine? Okay, that's normal. I know. What'd he say?
That hurts.
Yeah, I know. You'll thank me later, though, I promise you. All right. So, I know. Shot? All right. I'm going to give you a minute to settle down. So, folks, let's talk for a moment. You have a marking pen? I want it to be crystal clear why we're here today doing the Deuk laser disc repair. We're here because this patient has daily back pain in this area, and I'm going to show you why. And that pain goes down his legs, okay, when he's up getting around doing stuff. So basically it's back and leg symptoms. Now, it's very important when you understand spine issues and spine surgery, what the purposes of surgery are, what they accomplish. The surgeons, spine surgeons in the year 2021, today, what they want is they want to be able to unpinch the nerves when the nerves are being pinched by a herniated disc. And unpinching the nerves will fix symptoms from the leg down. So leg pain, leg tingling, leg weakness, and leg numbness. So pain, tingling, weakness, numbness. That's the goal of spine surgeons. Whenever there's a herniated disc and it's pinching on a nerve. Okay? What surgeons don't do is they don't fix back pain. If you talk to a surgeon today and you say, hey, my back hurts, do surgery and fix my back pain, they'll think you're crazy. But the reality is we've had a breakthrough here at Deuk Spine where we've discovered the cause of back pain is actually the herniated disc, but it's not the herniation itself. And that's the eye-opening, that's the big message, that's the big win, the big find, is that the pain is actually coming from a tear in the disc that everybody ignores except us here at Deuk Spine Institute. We started treating these tears 16 years ago and found that by treating the tear along with the herniation that we can cure back pain and neck pain and thoracic pain. All right, so we're going to be fixing 3 discs. They're herniated and causing his back and leg symptoms. Those 3 discs are the L34 disc, which is the top needle, the L45. Are you better now? And the L5S1, okay? Those are the 3 discs. 1, 2, 3. And all 3 of these discs have a tear in the back of the disc called an annular tear. By the way, you're going to get to watch this later, and you get to learn a little bit about your surgery, okay? So annular tears at L34, L45, L5S1. Our goal today is to fix his leg symptoms and his back pain both. It's unlike any other surgery in the world. We're going to fix both the back pain and the leg symptoms. To do that, I need to, number 1, get rid of anything pinching the nerves. So I need to do a decompression. And I also need to do an annular debridement. And the annular debridement is what's unique about my surgery. You won't find it anywhere else in the world. And if you do, they're copying my work. I published this result back in 2012. And that was after studying the results of patients that had this surgery and their outcomes. And they did amazingly well. So, decompression, very common in spine surgery. Pretty much every neurosurgeon knows how to do decompressions, but annular debridement is unique to this procedure, the Deuk laser disc repair. And we're going to go ahead and put this patient to sleep in a minute, but I need to test something first. Are you comfortable? Have you watched this surgery done before? Do you know what happens next? What? What do you say? You're a very smart man. A discogram. So the discogram is part of this procedure because we want to make sure that I can see the tear with the dye we inject, plus we can characterize it on X-ray, which we use for navigation. And also I want to know if the disc is causing his pain. How bad is that on a scale of 1 to 10? I'm sorry. All right, how bad is that? We're done. How bad is that? Scale of 1 to 10. 15. Is that your typical back pain? I'm sorry, just relax, settle down. All right. Folks, take a look at this. Can you guys see this pretty well? All right, we're okay. Breathe deeply, you're fine. And you want to blame anybody, blame the anesthesiologist. They're responsible for your awareness of pain. Or you can blame Luis. All right. So, look, I mean, the reality is, folks, we have to do the test. And it's unfortunate, but it's necessary. I need to know how much pain he's having from that disc. So we know that the L34 disc, which we took an X-ray of, you could see the herniation. This is a 15. Yeah, just leave that light on. 15 over 10. Okay, that's this disc right here, 15. That was pretty horrible. You could see how his back arched up when I injected. I injected a tiny bit of dye, by the way. I injected a couple of cc's. Okay, that's what I injected with right there. Now, some patients take more dye than others. The reason is their tear is bigger and they let the liquid out easily. All right? But you can see from the X-ray picture, he's got a herniation, he's got an annular tear in the back of the disc, and that's where his pain's coming from. And that's at L34. That's a top disc. We're fixing 3 discs. There's a needle in each disc. The top disc has the top needle. You can see the dye in there. You can see a tear in the back of the disc. That tear is where his back pain's coming from. And again, that was discovered by myself at Deuk Spine Institute, that the tear is the cause of the back pain. If you ask most neurosurgeons, they would laugh at you if you say the disc is the cause of back pain. They say you're crazy. About 98% of them will say you don't have no idea what you're talking about. The discs don't cause back pain. That's because they don't know. They haven't figured that out yet. I've been trying to tell them for years, but they don't listen. Honestly, they're too arrogant. So because of their arrogance and their unwillingness to listen and learn, they're letting their patients suffer with chronic back and neck pain and thoracic pain for years and years without treating them. It's a shame. And I hear these stories all the time. Patients go from doctor to doctor trying to get relief of their pain, and the doctors just keep turning them away or giving them treatments that don't work. Lay down. The only treatment in the world that works is the Deuk laser disc repair. I know. I'm going to try to make this a little more pleasant for you, okay? But you did great. Are you recovered yet? Yes? All right. I'll just do it a little bit. All right, how bad was that on a scale of 1 to 10? A 9? All right. 9. It probably is more than that, folks, but I just barely put anything in because his first response from the first disc was so painful. I didn't want to put him through that again. But we got a 9 out of 10. I think it's probably more like a 15 out of 10 again, but I wasn't going to push it. So a 9 out of 10 for that disc at 045. You saw that on the X-ray, right? The second disc, the middle disc. We're going to put you to sleep in just a few minutes here, all right? And I'm sorry that you had to go through this, but I think it's very important that we did it because it proves your pain is coming from these discs. Don't you agree? Yeah. All right. I'm glad you agree with me. How bad is that? A 10? All right. Is that your typical pain? Is that where you get pain normally, the same location? It seems like what? All right, but that's in your lower back. That's where you get pain, right? Yeah. All right, you get to go to sleep now, and when you wake up, we'll be done with your surgery, and your back pain will be gone forever. Isn't that amazing? You're welcome. Count out loud for me, 1 to 100. If you get to 100, I don't pay the anesthesiologist. All right, we'll take the question you have, Sean, at this point.
So we have a viewer on Facebook who's wondering, will this surgery help if you have pain even after a fusion?
Yes. Yes, this surgery, so the question from a viewer on YouTube is, or Facebook, is will this surgery help a patient who's had a fusion and they still have pain? The answer is yes, 100%. Here's why. Your pain after a fusion is coming from a structure that we can fix. So it usually is the disc above or below the fusion. Like 99% of the time, when someone had a fusion, they come to me with back pain or neck pain, it's the disc above the fusion or below the fusion that's causing that pain. And it can be fixed with this laser surgery. Now, sometimes, very rarely, I cannot get into that disc to fix it. It happens probably, if I had to guess, probably 1 out of every 70 patients that they come here, I try to get into the disc and I can't get in. Just because their facet joints are too big and I can't get around them. I just can't access the disc for some reason. It's anatomical. And there's no way for me to know that ahead of time. Shot? So it's unfortunate, but it happens. But yes, 99% of the time, the problem with the pain after a fusion is the disc above or below. It's called adjacent segment disease. All right. We're starting at L5S1. I've got my guide wire in. I'm taking out the needle shot. I want to make sure my guide wire is anchored properly. Do you see the guide wire? Huh? You see the tip? Shot? Yeah, it's there, right? I just want to make sure because he's got a lot of soft tissue. It's really hard to image him. Shot? It's really hard to like see because of the graininess. And we're using, can you take it off pulse? We're using the very best fluoro machine made on earth. It's a Siemens flat panel Arcadis, right? And we don't cut corners when it comes to quality here at Deuk Spine. We buy the very best because it makes a difference. It makes a difference in the results of the surgery. If you go cheap and you buy a cheap used fluoro machine that's like, I hate to say it, but like a GE, sorry GE, but it's the truth, and I don't lie on this show. If you buy like a cheap fluoro machine, you can't see anything. And then it becomes, honestly, not just less effective treatment, but dangerous. So as the quality of the instruments and the quality of the equipment go down in quality, the risk of complication goes up because you can't see what you're doing. We call it visualization. You can't visualize well. And then also the effectiveness of the treatment goes down because, well, you can't really see what you're doing. And it's important that surgeons can see as much detail as possible, as much detailed information as you can get. You understand? Thank you, Luis. That's what I needed. So that's why here our philosophy at Deuk Spine Institute has been and always will be, as long as I'm in control, it will always be you get the very best for the patient because I want my results to be consistently good, okay? So there's a restaurant close by called Nico's, and the owner, I know him. I know him because the food is really good there, and I go there quite often. As a matter of fact, we're having them for lunch today. I decided to provide it for my staff, but only the good ones, only the ones who are behaving. Shot. But Nico's is interesting because the chef has been creating food for about 40 years. And what's unique about him is it's not just the presentation and how he prepares, like the amount of time he cooks the food, but it's the quality of the food. The meat there, and I'm sorry for the vegetarians watching, but the ingredients are very, very fresh, and you can taste the quality in, for example, the meat. Meat is one of those things that a lot of chefs will try to cut corners, especially if they own the restaurant, because they're trying to make more money for themselves. So they'll provide meat, for example, that's tougher or like an older meat. You know, I can't really tell you the details, but the point is the quality is down. And that's how they save money. They cut costs by going less expensive on the ingredients, all right? And surgery is not much different. You cannot cut corners, otherwise it compromises quality. Shot. And so, you know, whether you're baking chocolate chip cookies or you're building a building, you want to use high quality ingredients, the best steel, the best products in the construction of that building or in the creation of that meal, because it makes a difference. Shot? It's hard to see. Shot? It looks like the tube's in there. Shot? Yeah. Right, Luis? We're in, right? Shot? Yeah, I agree. So, ingredients, quality, quality, quality. If you can't have the same results with a surgery on someone's back if you go cheap with the equipment and the drugs and medications and the staff, you know, the staff can make a difference. The people working for me can make a difference. So the anesthesia makes a huge difference. It's probably the second most important thing for the outcome of the surgery besides the surgeon, and maybe even the most important. So arguably, you know, so the anesthesia has to be really good. The anesthesiologist has to be really good. The surgeon has to do their job, but also all the staff and all the equipment and all the supplies and all the drugs, they all have to work properly. And if you go cheap, you know, with your stuff, which a lot of hospitals go cheap, a lot of hospitals and surgery centers go cheap. Is that him moving? No. Then that's why you get suboptimal, called suboptimal. Optimal is the optimum result. Suboptimal means below optimum. Suboptimal results are results that are below optimal, below the best possible, okay? So if you want the very best results in healthcare, whether it's a vaccine for a virus or whether it's surgery, you need to have the very best available in the world to get the very best results. And at Deuk Spine Institute, we have the very best equipment and staff in our center, period. And that's so important. I can't even begin to tell you. I moved out of the hospital because the hospital stopped giving the very best equipment. They've stopped giving the very best staff. They stopped giving the very best medications that I needed. I had to fight with them to get the best for my patient. And I got tired of fighting, to be honest with you. And it's not just me fighting. All surgeons fight their hospitals. All surgeons. All surgeons at every hospital and every ambulatory surgery center, they fight the hospital administration for what they want for their patients. Well, guess what? I don't fight anymore because I own the damn place. So I get to buy the best, and I always do. So having my own surgery center, Deuk Spine Institute, gives me the ability to provide my patients the very best care. And that's ultimately very important to me and the patient. Sometimes patients don't realize that. They think that a center is a center, and, oh, why are you more expensive, and can't we go somewhere cheaper? No, I'm not going to compromise your results because you just can't understand the importance of high quality care. So I'll be honest with you, as the CEO and founder, I don't tolerate shit from people. when they don't understand, even after I've tried to explain it to them. You know, I'm not going to be able to convince everybody what's important for them and what's best for them. Ultimately, I'll spend some time and effort doing it because I owe it to people to do that. But in the end, if people want to be stupid and go somewhere else just because their insurance doesn't cover a certain treatment, whatever, that's their choice. But they're compromising the quality of care. And that's why there's so many people out there, unfortunately, that have bad results from spine surgery, is because their surgery wasn't done right the first time, in my opinion. Okay? Their surgery may not have been done right the first time. Now, if the patient does something they're not supposed to do after surgery, they have a good result, and then they go out and mess it up on their own, that's different. But if they don't have a good result out of the center or the hospital, it could be because of the equipment or the staff or the surgeon's lack of training or experience or knowledge. It could be related to the anesthesia sometimes. One of the reasons I stopped going to one of the hospitals I have privileges at is because my patients were starting to get pneumonia post-operative, and I couldn't figure it out. They had respiratory difficulties, they had fluid in their lung, they had a pneumonia, and I'm like, why is this happening, you know? And it was a spurt of it, because I hadn't had it before. And I found out that the nurse anesthetist that the hospital hired was overloading them with fluids, you know? And they were creating complications in my patients, and that wasn't acceptable to me. That was the end, by the way. I don't go to the hospital anymore as a result of that. I won't go to the hospital, period, you know? I can't take a patient and put their life at risk unnecessarily because the hospital doesn't want to spend the money to hire a medical doctor, anesthesiologist. Instead, they want to hire nurse anesthetists that are not supervised properly by an anesthesiologist, and then they end up creating complications for my patients. That is unacceptable to me. Unacceptable. So, is it acceptable to other surgeons? Absolutely. They don't care. Or they don't know that they can care. Maybe they don't realize they should care, you know, but I realized over the years that I should care. I realized over the years that it makes a difference who's doing the anesthesia. It makes a huge difference in the outcomes of the patient's surgery. So I made it a priority for me to be able to control that, along with the drugs and medications, equipment, supply, staff. I made it a priority to control that. So I invested my own money. I took the risk. I took my money and borrowed money on my own name and my own credit, and I built this place, Deuk Spine Institute Surgery Center, because I wanted to be able to have full control over the quality of care that my patients experience. Anyway, digress a little bit, but here we are inside the disc. This is the L5S1 disc, and you can see there's some damage to the disc. It's not normal at all. And the tube that we're working in is called the tubular retractor. It's silver. You can see it. It's oval shaped. There's a window at 12 o'clock that's designed that way to open up at 12 o'clock and give me a better view, about 20 degrees more view up towards that end, okay? Now, for those of you wanting orientation, 12 o'clock is where the laser fiber is. This is the laser fiber. It's glass. It transmits laser energy from a machine in the room that you can't see. It's the size of a giant, like, oversized suitcase. It's huge. And it generates laser energy, which goes through this blue tube, which the blue is a protective plastic coating around the glass fiber. And the beam is emitted from the end of the laser tip right there, the glass tip. It comes out about 0.5 millimeter. You can see a red color right there, maybe a little bit of a red targeting beam. It's not, actually it may be off right now. But that targeting beam shows where the laser blast will occur. I don't need the targeting beam anymore. But this is all scar tissue right here, this white stuff, and it's very scarred up in here because this patient damaged their disc years ago. And the inflammation from the damage has been raging like a fire burning out of control, and it's caused a lot of damage inside the disc, and that's what I'm repairing. This damage is happening in the annular tear, and that's where we are. I'm repairing the annular tear right now. This is the hallmark of my surgery, the Deuk laser disc repair. It's an annular debridement, or a cleaning up of the annular tear. No other surgeon does this, and we are not doing a removal of a herniation at this second. We're actually repairing the annular tear. Okay? Someday everyone will be copying what I discovered, and that's okay. But I'm going to be trying to open Deuk Spine Institutes around the world so that people have access to this technology. Because unfortunately, the truth is that the companies that manufacture screws and rods and promote spinal fusions, they're completely against me. And they've got a lot more money and power and influence than I do. Thousands and thousands of magnitudes more than just one little surgeon doing this out of Florida. You understand what I'm saying? And until we have more recognition and more acceptance and understanding around the world, this technology, unfortunately, is going to remain buried, except for us, and we're trying to get the knowledge out. We're actually working on a Roku channel, a Deuk Spine Institute Roku channel, so you can sit there at home and watch surgeries as much as you want. We're going to put really interesting content. We're going to have question and answer sessions and face-to-face interviews. We're going to have surgeries you can watch 24 hours a day, 7 days a week, streaming, live. We'll take requests. If you want to, we're going to come up with a program and programming. It's going to be really neat. So if you have Roku, or, you're thinking about getting it, there will be a Deuk Spine Institute channel on Roku probably in the next 6 months. And all these surgeries and content will be available. We also have an app called the Deuk Spine Institute app. It's free. And if you want to download it and use it, it'll allow you to watch surgeries live, ask questions. Also, there's content in the app that explains diagnoses and treatments and why we do what we do. If you like the app, then give us a good star rating on the app so more people can learn about it and use it.
We have quite a few questions.
All right, let's bring the questions on. We're almost done with this disc, by the way. I'm getting close to the outside of the tear. You can see I'm working on the tear right now, but go ahead and ask a question.
We have a viewer on Facebook who's wondering, will this surgery help cervical spinal stenosis?
Will the surgery help cervical spinal stenosis? That's a great question. Stenosis, folks, just means narrowing. It's a Latin term. It's derived from Latin. It means narrowing. So cervical spine stenosis means narrowing of the spine. That's spinal stenosis. And cervical spinal stenosis means narrowing of the cervical spine. And what's narrowed is the holes where the nerves come out and the center of the spine where the spinal cord is. So there's two areas that can be narrowed. In some people, it's narrowing of the spinal canal where the spinal cord is, so they get pinching of their spinal cord. The spinal cord can get damaged from getting pinched. And then there's also narrowing of the neuroforamen where the nerves come out, and that's called foraminal narrowing. So when you say you have cervical spinal stenosis, we look and see, is it the spinal canal that's narrow, or is it the neuroforamen that's narrow? And narrowing of the neuroforamen pinches nerves and usually causes one-sided, but can be two, numbness, tingling in the arm, weakness in the arm, pain shooting down the arm. Narrowing of the central canal causes flattening or squishing of the spinal cord. That can cause balance difficulties, headaches, clumsiness of the arms and hands, weakness of the arms and hands, tingling in the fingers on both sides. So balance problems, coordination problems, loss of strength and muscle mass in the hands, those are all signs of spinal cord compression and central canal stenosis of the cervical spine. So eventually you go paralyzed from spinal stenosis in the cervical spine if it gets bad enough. The answer is yes, Deuk laser disc repair is the perfect surgery for fixing that problem, because we can fix cervical spinal stenosis, whether it's central or foraminal. We can fix that with the laser, just like we're doing now with the lower back. By the way, we have a special treat today. We're going to be broadcasting a thoracic disc herniation. Next, as our next surgery after this patient's done. And this patient that we're talking about has herniated disc in the thoracic spine at T11-12. And we're going to be going on both sides to decompress his spinal cord. We're the only place in the world that does thoracic endoscopic spine surgery that is transforaminal. Transforaminal. There are some doctors that go transthoracic. That's very invasive and dangerous. Has to be done with a cardiothoracic surgeon. But here we go transforaminal, which is simple and outpatient and much more elegant and less risky. All right. What other questions do you have there, Sean?
We have another viewer who's wondering, I've had 2 lumbar kyphoplasties. Is this surgery still feasible for my pain?
So great question. So this person has had 2 kyphoplasties. Kyphoplasties are different than what we're doing. We're treating a joint, aka the disc, which is located between bones. The bones have a name. They're called vertebrae. So the disc is like a cushion, like a hamburger patty, the meat patty between 2 buns. The buns on both sides of the disc would be the vertebral bodies or vertebrae, okay? Kyphoplasty treats the bones, the vertebral body. This procedure treats the burger meat or the disc, the cushion between the bones. So totally different problem. Now, if you've had kyphoplasty for your fracture and you still have pain, it could be several things. The most important we want to make sure you don't have is an infection. If your doctor has said, nope, there's no infection and the kyphoplasty looks good, then you're right. Their pain is coming from something other than the bone, and it's probably coming from a disc between the bones. So this surgery would be perfect for that. But it's really easy to know. All you got to do is go to deukspine.com and upload. Sean will put a link in. Click on the link, upload your MRI or CAT scan, and let us do a free review of your MRI. A free MRI review. And then we'll be able to tell you where your pain's coming from and whether this surgery will work for you. We're just about done at L5S1. You can see some of the posterior longitudinal ligament fibers and annular fibers. And we're just at the surface of the disc. We've cleaned up the tear. We've done our debridement. And I think this patient will do very well at L5S1. That's pretty much it. There should be a nerve root right here, and there it is. Look at that beautiful nerve root. That's the dorsal root ganglia of the right L5 nerve root, right there. That's the dura covering it. And that's where the herniation was, right there in the armpit of the herniation. Of the nerve root, sorry. Pretty incredible view, huh? That's endoscopic surgery for you, the future of spine surgery. We've got 1 disc done. Scope off. We're going to do the next 2 discs. Magic juice. All right. Any questions so far about what we're doing and why we're doing it?
We do have a question. We have a viewer asking, do my 2 lumbar kyphoplasties preclude this surgery?
We're going to need a towel here. Sorry, folks. We have a little water on the floor. And no, I did not lose control of my bladder. So, do my 2 kyphoplasties preclude the ability to do this surgery? You can come in with the fluoro. All right, you ready? The answer is no. You can still have this surgery done even though you've had a kyphoplasty. But understand, this surgery does not treat fractures of the bone. This surgery treats joint or disc problems between the bones. So yes, you can still have the surgery done even though you've had a kyphoplasty. Watch your head. As long as you need the surgery done, you can leave it there. Yeah, just leave it there. That's perfect. Thank you. Does that make sense? So The kyphoplasty treats bone fractures. The Deuk laser disc repair endoscopic surgery treats disc problems. The disc is between the bones, so totally different problems. But yes, you can still get the Deuk laser disc repair done to fix a disc that's painful, located between two fractured and repaired vertebrae. No problem. We do it, by the way. We've done it before. Many times. Not an issue. All right, so we need to drop the fluoro or raise the table, one or the other. How do we drop the table? I know what you're saying. All right. I don't. Do you think so? I doubt it.
We have
You're
another
not that
question whenever
strong.
you're ready.
Yes, I'll take a question. Sean?
One of our viewers on Facebook is wondering, are there any back issues you don't think you could fix outpatient at your center?
Are there any back issues we can't fix at the Deuk Spine Institute? Great question. There are just a couple that we cannot fix, that we probably could fix, but I don't want to fix. Let's put it that way. Why? Because they're very rare, and they're higher risk, and they're much more long and complicated surgeries. But we probably could fix it if we had to. You know, if somebody really compelled me. The reality is that, you know, we've done pretty much, we've taken tumors out of the spine here. We have corrected deformity, long segment deformities, which is like scoliosis, kyphosis. We've done osteotomies. So we've done posterior cervical laminectomy and fusion with instrumentation. There's really not much we can't do. I would not do a couple of surgeries. Number one, I wouldn't do an anterior thoracic corpectomy, which is where we have to take a rib out and go down in the front of the spine with a patient on their side, drill away a vertebral body or two, put in it's a column, like a cage, a really big cage, metal cage in the front, and then flip the patient over and put in screws and rods in the back. So I wouldn't do any really complex tumor or fracture reconstructions. Those are best done in the hospital. But those represent literally 1 in 5,000 spine surgeries. It's so rare. The second type of thing I wouldn't do would be juvenile idiopathic scoliosis, which is in children that have really bad scoliosis, and they need like screws and rods up and down their whole spine. We wouldn't do those here. Could I do them here? Sure. Do I want to do them here? No. They're better off in a pediatric hospital where they would get better care after surgery, Sean, which we can't provide them that kind of care here. I mean, could I if I had to? Yes. But I don't want to do that. There's no real need to do that. These other facilities are better suited for that. So really, infections of the spine, we could do some infections. Complex fractures that are in the front of the spine. Somebody who's acutely paralyzed, that just got paralyzed in a motor vehicle accident or something, I wouldn't want to do them here. We're not really equipped to do that. So those types of very weird, rare, very complex, it's not so much the surgery that's complex, it's the aftercare that the patient needs to be in a hospital. And that represents, with all those surgeries, probably 1 in 1,000 spine surgeries that are done. Sean? So I wouldn't want to do those. Now, what we treat here at Deuk Spine is like the bread and butter. We call it bread and butter. It's just the most common types of problems involving the spine. Herniated disc, bulging disc, degenerated disc, slipped disc, ruptured disc, extruded disc, and then spinal stenosis, narrowing, foraminal narrowing, central narrowing, some deformity like kyphosis, scoliosis, listhesis, fractures, minor fractures like vertebral body fractures that are easy to fix with kyphoplasty that don't require complex surgery. So, that kind of stuff. How's he doing? Good? Shot? All right. We're done with one disc. We're going to get to the second shot. Shot. It's going good. It's a great question you're asking, Shot. And the reality of it is that the vast majority of degenerative spine surgery is done for disc problems. Herniated disc, ruptured disc, degenerated disc. And that's what we fix with the Deuk laser disc repair. This is a disc surgery. It's done to repair damaged discs. And any kind of damage, whether it's completely collapsed or it doesn't matter. If you have a problem with a disc in your spine, which is like 95% of spine surgery these days, it can be fixed with this surgery. Okay? You don't need to have open back surgery anymore if you can make it here.
We've got another question.
Sure.
It looks like this question is coming from another physician who uses laser endoscopic surgery techniques.
Oh.
He's asking, when we use laser, it's very easy for us to destroy our instruments and the endoscopic rig. How do you avoid doing that?
Great question. So first of all, I would love to know what endoscopic rig you use. Is it a Wolf? What's the manufacturer? But so the manufacturer is important because the way you destroy your rig, usually, folks, and whoever the doctor is, thank you for asking the question. It's a great question. The way you destroy your rig is, let me show you. Let me have the laser fiber. So there's two ways to ruin your rig. One is by bending, by flexing the shaft of the endoscope. And I've done it before when I'm really trying to get more medial, to see medial where the herniation is. Then I'm taking my hand and I'm dropping it. And when you're inside the rigid tube, what that does is it flexes or bends, like it puts a force here down and a force here up. It kind of bends the actual shaft. So that will actually cause the lenses at the ends to shift. And once the lenses shift just half a millimeter or a few degrees, then you're out of focus. So that's one thing you have to be aware of is pushing down on the scope or lifting up. So you cannot force the shaft to bend, period. Keep it straight. You can put some force on the tubular retractor, up, down, sideways, but you cannot put force on your camera or the shaft. You'll ruin it. That's number one. Number two, which I've done this too, is you see the laser fiber goes in to the working channel, comes out the end, right? And so I'm working like this with the end of the laser fiber that is, push it in, right there. The laser fiber is transmitting energy outside of the end of the scope. If you accidentally pull the laser fiber inside the shaft and you push on the pedal to release the burst of energy, it'll shatter the lens. So I've done that. It's expensive to fix. So those are the two ways that I think are common ways of damaging your scope during surgery. Flexing the shaft and then pulling the laser fiber in and hitting the pedal and releasing the energy while it's inside the scope. Don't do that. You should always visualize your laser fiber outside. All right, that's my current picture. Can't tell if we need to go in a little more with the shaft, so I'm going to pull the dilator out, Shot, and just see where we are. It looks like we're inside the disc. You want to be sure you're inside the disc with the tubular retractor tip. And to me, it looks like we are. Shot. So I'm going to use my fluoro to navigate the dilator out of the disc space. So it looks like we're in with the tube. We're good. I don't know if that answers the question for you guys, but those are the two things that I can think of right now off the wall that would be the reasons that you're damaging your scope.
Also, who's taking care of the scope?
Huh?
Also, who's taking care of
Yeah, and then of course the person cleaning your scope. But they said, I think they said during surgery, but maybe they didn't. I don't know. But so it could be the person cleaning your scope too. Obviously, you want to make sure you're cleaning it properly. I would talk to the manufacturer and see what they say. Did we ever get a name of the manufacturer, Sean?
We did not.
Okay. All right. Well,
scope on, please?
maybe they don't know. Okay, we're going back in. This is L45. The disc, the second disc we're repairing endoscopically. Have I not given you any samples? You have sample?
I have.
So
Lights off, please.
we're going to get started at the next disc.
Thank you.
We've got about 20 minutes more, doctor, for the anesthesia. All right, so there's our second tear. There is one more thing. I don't know.
Ready? Okay. So watch the steps.
Thermally, it could be a thermal issue as well. I use cold saline or lactated ringers to cool my laser and the tissues and the equipment. You may not be using cold saline. So I would recommend refrigerating your saline, and that will probably help as well if you're not refrigerating your fluid. There's a piece of herniation, standby laser. And I assume the equipment you're talking about damaging is your scope. If it's just your tubular retractor, you can see I have a lot of laser blast marks on the stainless steel. The laser is very powerful. We run ours at 15 watts.
15 hertz to use.
Oh, sorry, 15 hertz, 2 joules. I apologize. So 30 watts total. So I don't put my laser up that high. It could be that your laser is also set too high of a energy setting. You don't need it for a disc. You don't need it for a bone spurs. You just need 30 max. 2 and 15 are my settings.
We have another question.
Sure.
A viewer on YouTube says, I have a 3-level fusion at L344551. I still have pain on the daily in my thighs and hips, and it's really bad in the mornings. My surgeon told me the pain comes from the arthritis in my spine. Is that true, and can it be fixed?
Great question. So somebody's had a 3-level fusion in their lumbar spine, and they're still having pain in their hips and thighs. And the surgeon that did their surgery tells them it's coming from arthritis in their spine. Can it be fixed, and is it true? The truth is that I can't tell you exactly why you're having pain in your hips and thighs unless I can see you. And we give you that opportunity for anyone in the world that wants a free evaluation. We do that at Deuk Spine Institute. And it's done with Skype, using telemedicine, for lack of a better word. So the truth is that there are many causes of hip and thigh pain that have nothing to do with the spine. And there are causes that do have to do with the spine. For example, if you have an infection where your surgery was, that would be definitely a cause of hip and thigh pain, an infection, okay? Seen it before, not recently, not in the last 12 years for myself, but I know it happens with other surgeons that have patients with spinal infections after surgery. Another cause could be loosening of the hardware and a failed fusion. It's not a common cause, but it can happen. Another cause that's not exactly at the fusion site, but adjacent to the fusion would be a problem with the disc either above the fusion So that would be the L2-3, for example. Another cause for you could also be your hips. And very commonly people get problems with their hips when they have spine problems. Part of that is because of the way they're walking with bad back. Changes the way you walk and you can wear out your hip joints. The other problem that happens is you can get a problem with your hip joint called avascular necrosis of the femoral head. And it's basically damage to your hip joint that results from the use of steroids. So people who have fusions, frequently they start out by having a lot of steroid shots, and those steroid shots can ruin your hips. It's not common, but it does happen. It's called avascular necrosis of the femoral head. Okay? Then you could also have piriformis syndrome, spelled Piriformis. You could have sacroiliitis, which is very common, or sacroiliac joint dysfunction. That could be a cause. You could also have a problem with the muscles, basically. Whether it's a medication you're taking causing it, it'd be very common. So, unfortunately, there's a lot of different causes of your symptom. But assuming it's arthritis is the wrong thing to do. And is it fixable? 100% yes. It should be once you figure out the cause. The problem is that most doctors can't figure out the cause. And if you don't know the cause, you can't come up with a solution. It's impossible. So what we do better than anyone else in the world at Deuk Spine Institute is we find the cause. But that requires for us to examine you and to look at your films. So if you want to upload your MRI for free, we do a free review. It's called mri.deukspine.com. Sean will post the link. Submit your MRI or X-ray, post-op X-rays or MRI or CAT scan. Let us look at it and let us help you. We can guide you. Even if you don't treat with us, it's fine. We're not looking for your money or your business. We're just trying to help people that are suffering and can't find solutions to their pain. We can find the solution for sure, but we need more information to do that. So I'd be guessing right now if I told you a reason. I'd be lying to you, and I don't lie, period. So we're happy to help you for free. If you can just get us some pictures, like a CAT scan or MRI post-op, preferably one of those two. An X-ray would also be okay, but an X-ray is not as good. And then I would need to see you on the film, on the Skype, and be able to examine you through Skype. If you're in Florida, just drive over here. We're in Florida. We're in Melbourne, Florida, Deuk Spine Institute. We're near Orlando if you want to fly in and be seen. We will even do a free initial evaluation if you really want for us to evaluate you. It's not a problem. We can do a free initial history and physical. We may have to order additional tests to figure out what's wrong. We frequently do, but we can figure it out for you. So for whoever asked the question and whoever else has the same problem where you've had a fusion surgery, you're having pain, you're not sure what's going on, don't settle for the answer of there's nothing that can be done about it, okay? Or just go get shots or go do physical therapy. A lot of times the shots and therapy don't work for this kind of problem. So you need a diagnosis. What you really need is a proper diagnosis. That's what we can offer you. Stop. All right, we're working on the L45 disc. I can tell you this disc is structurally much more damaged than the one we just did. We just finished L5S1, now we're at L45. You can see the damage to this disc is long-standing, chronic. This looks like crab meat, like kind of old, dry crab meat. And it feels like it with the laser as well. There's calcification there. You can see the gold color. It's all calcium. So I'm glad to know we have another endoscopic spine surgeon or more watching. I would love to know what country you're in, where you are, what your name is. We don't get a lot of endoscopic spine surgeons watching my surgeries, but I'm glad because you are one of our target audiences. We want you to watch and learn so you can help more people. We broadcast our surgeries live for free around the world. We broadcast on Facebook and Periscope and YouTube. 3 platforms. Currently, we're going to be broadcasting on Roku in about 6 months. So anybody with Roku will be able to watch on their television. And it's an exciting time for people with back and neck pain because it can be fixed now. You don't have to live with it anymore. But we got to get the word out. That's the biggest problem. People don't believe it. They don't know where they can go because nobody else can fix these problems. Just a very few number of doctors around the world can fix these chronic back and neck pain. So when people go to their doctor and ask for help, they can't get it because the doctor doesn't know how to fix it. That's unfortunately the case, and that's why we want to raise awareness, right? Raise awareness. We're raising awareness about a problem, but also a solution. Unfortunately, the solution right now is available only at Deuk Spine Institute here in Florida. Sean, did you have another question?
We don't have any others right now.
All right, we're just about done. That's the end plate, by the way, that pinkish surface. That's going to be the end plate of L5, the superior end plate. Here's the end of the disc herniation. Just look at all this scar tissue from chronic inflammation. All right? And the reason there's scar tissue here in the disc is because, contrary to popular belief, the disc does have a blood supply. The disc does have a nerve innervation supply. It's just not in the center of the disc or middle of the disc, but it is on the outer half of the disc. Now, with injuries to the annulus, that blood supply and nerve supply will grow into the center of the disc, actually, over time. But it takes chronic inflammation to do that. Inflammation is part of our healing process. If you injure a part of your body responds through inflammation, first and foremost. The first response to any tissue injury is inflammation, all right, except for the brain. And all other tissues go through an inflammatory process, the disc included. And that inflammation results in the ingrowth of more blood vessels and pain fibers. And that's why people have back pain from their disc, from their annular tear. Again, that was the discovery made here at Deuk Spine Institute by myself. The first surgeon I know of that noted that disc can cause pain was Dr. Cloward, but he didn't understand the mechanism or the pathophysiology, and he certainly, he was a surgeon who developed the fusion technique, and fusions can help with pain if it's done properly at the right levels. But now we have endoscopic surgery to cure pain, and the Deuk laser disc repair is the surgery that is performed endoscopically to cure pain in the back and the neck and the thoracic. We're just about done with the L4-5 disc. This is all scar tissue, and there's herniation and tear associated with it. Had some great questions from our audience today. People always ask me, Dr. Deukmejian, my jelly is gone from between my bones in the disc. Is that going to be a problem? The answer is no. It's not going to be a problem. We don't need to replace the jelly. I'm going on record saying that because it's true. There's going to be all kinds of technologies coming forward in the next few years to replace jelly. They've already tried doing it for 20 years, maybe even longer. It doesn't work, and more importantly, it's unnecessary. It doesn't do anything. You don't need the jelly. The jelly is not the issue. It's the jelly's effect on your body's inflammatory system that's the problem, not the presence or absence of jelly itself as a cushion mechanically, but it is the physiological effect of the jelly. The nucleus pulposus is the jelly we're talking about. It is the physiological effect of the nucleus pulposus on vascularized tissue, which is pro-inflammatory. That is the effect. Just about done. There's the very end. There's epidural space, a little bit of fat cells in the epidural space. So for the doctor who was asking me earlier, endoscopic surgeon who was asking me earlier, how do you damage your scope with a laser? It's very easy. A lot of people don't know that the laser creates a shock wave. The shock wave itself is extremely powerful, very powerful. And if I were to create a shock wave inside the laser right up here, it will knock the lens out of place. So, you know, the laser pulse itself will damage the lens either thermally or mechanically. And that's probably one of the sources. The other being yorking. We call it yorking. Is when you kind of pull and twist. Yorking on your endoscope. I don't know if you can appreciate the yorking description or definition or vocabulary, but that's what it is. All right, since there's no questions, I will say that our next surgery is going to be a thoracic T11-12 disc herniation in a patient with bilateral stenosis of the thoracic spine at T11-12 due to a broad-based disc herniation. The patient also has a lumbar herniation, but he's not having that treated. He's chose not to. He just wants the thoracic disc treated at this time. Thoracic disc herniations are different than lumbar. They're more risky to treat. They're also more dangerous for the patient not to treat. What I mean by that is a thoracic disc herniation pressuring on the spinal cord will cause damage to the spinal cord. And we all know spinal cord damage is permanent. So you want to avoid any kind of permanent damage to nerves in your body, right? So he's trying to avoid permanent damage, so he wants his thoracic disc herniation treated. The problem is there's very few surgeons in the world that know how to treat thoracic disc herniations that are causing compression of the spinal cord, I being one of them. And most of those surgeons will offer fusion and very, very aggressive, open, bloody, painful, massive, risky types of surgeries, right? Filleting the body open, moving the muscles of the spine and taking out bones, and then of course having to fuse afterwards. So I offer an elegant transforaminal laser endoscopic surgery called the Deuk laser disc repair. And our patient has traveled from California, I believe, to have the surgery done here because it's not offered anywhere else in the United States, let alone world. I am the first surgeon in the world to do thoracic disc herniations endoscopically with a transforaminal, posterior transforaminal approach. So far I've done, I believe we're at 7 or 8, and this will be our 8th or 9th case. So we're still under 10, so it's not a big number. I just started doing them in 2020. I did it because patients were desperate and they had no other way, nowhere else to go. So they begged me and I did it, and I'm glad I did because it's worked out pretty well so far. Stand by, we're done here. So you want to see the nerve here? This will be the L4 nerve root. As a matter of fact, I don't see it, it's embedded too much, but there is a little bit of herniation there. Let me have the laser back. Ready? I'm ready. So Sean, right there, would you make sure there's a fresh pot of coffee?
Absolutely.
I feel the need for a fresh cup of coffee. That's my drug, by the way, folks. I shamelessly admit it. Coffee. Caffeine. I need my caffeine. Sorry. For those of you, I'm not perfect. How's he doing? Good.
He's just got a little obstruction, sleep apnea.
Oh yeah? Sleep apnea. What's that? Just kidding. I'm sure I have it too. All right, all done. Anyway, the nerve is in that tissue there. Let's see if I can grab a little bit of that out. Give me the grabber. Make sure there's nothing loose. Just about done with this L45 disc, and then we're going to get to the L5S1. Yeah, let me see the laser again. So sometimes when I think I'm done, I'm not actually done. I got to go back in because I see something I'm not happy about, and I work on it. Huh? Yeah. I'm not gilding the lily. I'm just want to make sure things heal up properly. Pretty happy with that. All right, we're done. Take that. Let's suck all the water out. Scope off. Oh, 2 down, 1 to go.
Lights on, please.
All right, so let's move some of these cables over to your side. And you can see some of the herniated material. Can you guys see this, Sean?
Yes, we can.
All these little bits and pieces, fragments of disc herniation. And they've just floated out of the tube. Let's bring the fluoro in. All right, I'm going to take this tube out. But let's just show the audience for a second real quick. You all see this? This is the endoscopic channel or tube. Hello? Right there is fine. Can you see this, Sean?
We can.
The whole surgery is done through this 7mm tube, and we did it all through one incision. I just wanted to show you that. So one tiny 7mm skin incision. I'm fixing 3 painful discs. That the only other way to fix this patient, folks, come on in, would be a fusion. And it has to be done properly. That would be the discs would need to be removed and cages put in through the back. It's called a TLIF, transforaminal lumbar interbody fusion. And we need to put in screws and rods, and we need to do osteotomies because the guy has really short pedicles and he's got narrow foramen and lateral recess. So the nerves are getting crushed right there. But I'm able to treat the lateral recess and the foramen both with this surgery. That's not something I've talked much about, and I'd like to address it. They're really shot. So try to wag it. There's really spinal stenosis. Let's talk about that for a moment. Spinal stenosis is the reason the nerves are affected, and it's the reason people have leg symptoms if they have a lumbar herniation. It's the reason that they have pain radiating around their rib cage from their back if their thoracic is affected, and it's the reason their arms have symptoms if they have a herniation in their neck, okay? The involvement of the nerve root itself. Now, I want to talk about it for just a moment. Put some pressure, please. Pressure, please. We're having a little, how's our blood pressure?
Going in and out of AFib. He's got a history of AFib.
Are you comfortable proceeding, or should we stop? All right. We got 1 more to go. Should be 15 minutes max. All right, so I'm gonna, while we're waiting for things to stabilize for a second here, we're gonna talk just for a moment. This is important. Nerve symptoms in patients with disc injuries or spinal stenosis, basically the same thing. Nerve symptoms come about because the nerve is affected. Now, I chose the word affected for a reason, okay? I didn't say compressed. Compressed means squished. I didn't say inflamed, because inflamed means inflamed. It means it's irritated chemically. Okay, shot? But it's important to take away that nerve symptoms come from the nerve being affected by either compression or inflammation. And here's the earth-shattering news. 98% of the time it's inflammation, not compression. Here's why most neurosurgeons and spine surgeons fail. Because all they think of is compression. All they're looking for in MRI is compression. And if they don't see a big compressing herniation or really bad stenosis, they turn the patient away from treatment and tell the patient there's nothing that can be done. That is the problem. That is the problem. The surgeons don't understand the pathophysiology of spinal stenosis and radiculopathy or radiculitis, period. And it's something that I had to figure out over the years on my own by understanding and paying attention to my patient's disease, their structural imaging, and their results from doing surgeries like fusions or laser surgery that I do. It's only through my own experiences did I learn the truth about radiculitis, radiculopathy, which is nerve involvement. And that truth is that most people's symptoms in their arm or leg come from inflammation of the nerve root rather than compression of the nerve root. Shot? Okay, let me have that back again. So, what is that? Why is that important? It's important because 99.9% of doctors that treat radiculopathy symptoms will ignore patients and turn you away if you don't have a big herniation squishing the nerve root. But I just got through telling you that big herniation squishing the nerve root is the massive minority of symptomatic patients. Most patients with symptoms don't have a big herniation squishing the nerve root. And here's the disconnect. It's inflammation from a small herniation, actually the annular tear, that is the reason why these patients have their symptoms. Inflammation, not compression. So, the Deuk laser disc repair that we're doing treats both. Traditional spine surgeries like laminectomy, microdiscectomy don't treat both. Most fusions don't treat both. Artificial discs don't treat both necessarily. The only surgery in the world that treats the inflammation and compression is the Deuk laser disc repair. That's it. Or a TLIF, transforaminal lumbar interbody fusion. And the reason is you have to cut the back of the disc out, which is where the tear is, in a TLIF to put the cage in, if it's done properly. And that's the other problem, is a lot of TLIFs aren't done properly. So, the only surgery 100% of the time targeting inflammation of the nerve root in the back of the disc, at the level of the disc that's herniated, is the Deuk laser disc repair. Bam. There it is. Knowledge, truth, understanding. They go together, folks. So why don't other doctors want to learn? Because they don't treat pain. Only pain management doctors, chiropractors, therapists, they treat pain. Anesthesiologists, but only when they're, under certain circumstances. Okay? But the doctors that treat pain can't fix an annular tear because they're not surgeons. The surgeons are the neurosurgeons and orthopedic spine surgeons. And they don't understand this disease at all. They don't understand it, and they don't know how to treat it. Sean?
We have another question.
Yep.
One of our viewers on Facebook is wondering, if I decided to travel down there from where I live and get this done, would I have to go off my blood thinners? How long would I have to be off them, and how would you manage that?
Great question. So one of our viewers said, hey, if I want to have endoscopic spine surgery, do I have to come off blood thinners? The answer is yes. You have to. And how long do you have to be off your blood thinners? It really depends on, number one, what blood thinner you're on. Number two, why you're on blood thinners. What's the disease you're treating with the blood thinners?
Come on, please.
And, you know, I can't just give you a generic answer. I'll give you a few scenarios. The worst, most extreme case of blood thinner would be somebody with a mechanical heart valve. A mechanical heart valve patients, they're on blood thinners for the rest of their lives, like Coumadin, and they cannot come off the blood thinner, you know, without having a massive risk of having a stroke. So somebody with a mechanical heart valve is on Coumadin. We would want to admit them and get them converted to heparin, and then we would stop the heparin a few hours before surgery and do the surgery and then put them back on the heparin right afterwards, and then get them back on Coumadin. So that's the most extreme example. If you're on blood thinners for a more benign condition, like AFib, then you could come off of them for about 5 days before. But it's really an individual case by case discussion. And it really has to take into account the disease you're treating with the blood thinners and the actual blood thinner. For example, people will take blood thinners when they've had a pulmonary embolism, right? So it's a blood clot that forms in the leg or arm and goes to the lungs and can kill you. Those people are on blood thinners usually for 6 months after the cause of their blood clot has been treated. So, you know, people are on blood thinners if they've had an aneurysm coiled in their brain. So I need to know why you're on blood thinners to be able to answer the question, and I need to know which blood thinner you're on. It's that simple. There's no one answer for everybody. That would be dangerous and irresponsible. So I don't know if that answers your question or not, but the most common scenario is that people would be off blood thinners for 5 days. 5 days. So if you want to know if you can come down here and get off your blood thinner, you go to your doctor that puts you on the blood thinner where you live. All right? Say it's your cardiologist. You go to your cardiologist and say, hey, I want to have minimally invasive endoscopic spine surgery. Can I come off my blood thinner for 5 days before surgery? And the cardiologist or doctor will tell you yes or no. I prefer you to be off blood thinners for 5 days. I really prefer 7. But if there's a big herniation right there. If I can't get 7 days, I'd be satisfied with 5. And in some cases, I would even do 3. So it just depends on what part of your spine I'm fixing, and it depends on how many discs I'm fixing. So there's all those things that have to be accounted for. This is a big piece right here. This is a major herniation. I'm going to see if I can wiggle it out. It may not come through the tube, it's so big. I'm giving a little jiggle, a little jaggle. Oh, nope, it broke it. Got excited for a second there, thinking we were going to be able to pull out a giant tuna. Right? Oh, there's a piece. This may be a bonita. Getting those giant tunas are so rare and difficult. You rarely ever find them. Oh yeah. That's a decent piece right there. I love it when a plan comes together. That's a flashback. If you were an A-team character, which would you be? Luis?
18 character?
A-team. A-team character.
You mean the 18?
The A-team. Yeah, the A-team. Remember Mr. T and Hannibal and Face? There was one more. Which one would you be?
I don't remember them. I know there was a crazy one.
The crazy one.
Yeah.
Is that you?
Yeah,
Muy loco? Huh?
Yeah, it's funny.
What was his name?
I don't remember
What was the name of the crazy guy in the A team? He was a skinny, crazy guy. I think he used to fly the helicopter most of the time. Sean, we have an answer to this 1980s trivia? All right, we got about 5 minutes, maybe 10 max to go, depending on what I find, Doctor. Okay? Dr. Pettit? Sean, are you still there? Look at this tear. It's huge.
I am trying to find the answer for you.
If you just do 18 characters and read them out loud, and I'll tell you which one it is. Huh? Murdoch. That's it. Murdoch.
Yeah, Howling Mad Murdoch.
It's Murdoch. So Luis would be Murdoch. Dr. Pettit, how about you? Who do you relate to?
He looks like the
Not what he looks like. I want to know its personality or whatever.
one who
Which one? Hannibal? Hannibal. All right. You actually look like him, so that helps too. Jordan? Huh? No clue?
so young.
All right. There were no female characters, unfortunately. But if there were, which one? No, not skin color. You choose. Who do you relate to? Mr. T. I love it. Yeah. All right. Huh? He didn't take shit from anyone. Do you know the A-team? You're too young. You don't remember them. All right. Fair enough. Well, when people don't ask questions, we got to digress and make it interesting. 5 minutes is what I think we got. Now, this disc herniation, this disc injury, this is L3-4. This is the top disc. If you remember, this disc, when I injected it, the patient almost came off the table. He was really unhappy about it. It was so painful for him. You can still see remnants of the blue dye in the disc. So he said this was a 15. When I said on a scale of 1 to 10, how bad was it? He said 15. And, I can tell you he was in a lot of pain. So this disc is a very painful disc, all right? Just keep that in mind as we repair it. So where is the pain coming from? Why is this disc so painful compared to the other two? Why is this one so bad? And I'm going to try to see if I can answer that. I don't really have an answer right now, but it's always has something to do with the annular tear. It's always due to the annular tear. Has nothing to do with the size of the herniation. Size of the herniation doesn't matter. Some pinkness over there. There's a piece of herniation right there that's wedged into the tear. What's that?
Just giving some forward.
So by the way, another interesting point for those of you watching the surgery, how many discs did we fix? 3. Why do we fix 3? Because they were all painful. So the key here is most spine surgeons will only fix 1 disc at a time. It's no wonder why patients still have pain afterwards, right? Yeah, we need a few more minutes, so I do need you to switch. There's a bunch of bubbles in there because we're running out of irrigation. We're switching the bag to the next one. That looks like a herniation there. It's getting a little cloudy. Let me see a 4x4 array tech. I hope it's just temperature change. We call that a thermocline. It's a term that divers understand, right? Are you a diver?
Yeah, but I used to study with the Navy, internal waves that travel on the thermal line.
You used to study what?
Internal waves that travel on the thermal line.
Oh yeah.
It's an interface between the
Really?
worked in the Navy. The radars, the sub, study the surface structure, specifically study the internal waves. It's pretty crazy.
You mentioned subs,
Yeah.
and you bring back one of my memories from college. Some of you may know that I went to UC San Diego,
That's where I studied for the places.
right? The nuclear sub base, Point Loma.
Yep.
Yeah,
Yep.
that's it, right there.
Yeah, I loaded the equipment and there was a platform right off mission.
So this was before you were a physician?
Yeah, I used to be an electrical engineer. I
You
did.
used to be a what? Electrical engineer. I'm talking to my anesthesiologist right now, Dr. Pettit, and we're reminiscing. He used to be an electrical engineer. Apparently he worked in Point Loma in San Diego, right where UC San Diego is, where I did my undergraduate. So I was pretty poor as an undergraduate student, and my roommate's dad was, he was a contractor for the Navy, and he would repair seals, water seals on board boats and submarines. And so my one job I ever had before I became a doctor was I worked for one day on a weekend. I went and repaired a seal on a submarine, a nuclear sub, with my friend and his father. Pretty crazy, huh? College student gets clearance to go on a nuclear sub and repair the seal. Of course, we were under guard the whole time, but it was pretty cool. I got paid $100 for the whole day. I thought that was a lot of money. Back then it was for me. But yeah, that was an interesting experience. The only paid job I ever had before I became a doctor was I worked one day on a nuclear submarine in Point Loma repairing the seal. He needed some lackeys to help him. We had to be, I remember we had to be up at 4 in the morning to get there by 6 to get started. It's not easy for a college student to get up at 4 in the morning. And I used to get up at 3:30 in the morning after that, because I wanted to be a DJ, and I had the 4 to 6 show, 4 to 6 in the morning radio show. All right, there's a piece of herniation coming up. So I would get up, I lived on campus, I would get up at 3:30 and I would skateboard over to the radio station and do my show from 4 to 6, and then turn it over to somebody at 6 o'clock in the morning and go back to bed. It was a really nice time. Just the campus was always empty at 4 in the morning. I don't know how many people actually listen to my show. Probably not many at all. Maybe 5. But I used to get requests, even at 4 in the morning. Requests for songs. This is the old days, you know, when people used to call into radio stations and request songs. They don't do that anymore. Isn't that incredible how much that's changed? Yeah. As a matter of fact, they based songs, new songs that came out, like Madonna, her songs, or anybody, U2, Michael Jackson, doesn't matter who the artist was that created the song back in the 80s. They used to base their popularity on the Billboard charts based on the requests by the audience for those songs to radio stations around the world. And people don't know that. That's a piece of history. So there was a pop chart around the world, number 1 song in the world, number 2 song in the world, number 3 every week. And it would be updated, and it would be updated based on the requests for those songs by the audiences listening. Some of you are old enough, and maybe you're from the LA area, you remember KROQ. I don't know if KROQ is still around, K-Rock. But that was a very popular station when I was a kid, when I was 16, 17, K-Rock. Of course, there was MTV as well, but they didn't broadcast on radio. Radio was the big thing. back then, back in the 80s. Everyone listened to their radios in their car, at home. And that's how we got our music, through a radio. Remember those days?
Oh, yeah.
Oh,
I'm
yeah.
from the 70s.
Yeah, you're from the 70s, so 70s, 80s, even 60s.
8 tracks.
God, yeah, LPs, right? I had a whole collection of LPs. LP is liquid plastic, vinyl. Huh?
Long plane.
Long plane, is that? Yeah.
45 for long plane.
You're right, the 45, so in the long plane. The 45s were like the tiny little ones. I remember those. They had a bigger hole in the middle, remember? You had to use an adapter for them.
One song on each side.
Huh?
One song on
One song on each side. My God, those were the days. Record players. We used to have a record player. How many people out there listening had a record player when you were growing up? Right? And then it went to tapes. And then from tapes to CDs. CDs to DVD and laser discs. Like the Deuk laser disc repair. All right, so it's taken a little longer than I expected, but we're making great progress. We're almost done. That pink thing is the end plate of L3. We're at the end of the tear now. Very superficial within the tear in the disc, almost in the foramen. And remember, I told you my technique is a inside-out technique I learned from Dr. Anthony Young. Dr. Young, and he used to have fights with other endoscopic surgeons over the best technique. And there's some epidural fat, so we're just at the end of where we're going to work. Dr. Young told me that he used to fight with other endoscopic surgeons in the early days of endoscopic spine surgery, back in the 80s, 90s, 2000s. This is Dr. Tony Young, for those of you who don't know. He was one of my mentors. I was one of his proteges. And he was an advocate for the inside-out technique, which he describes in his papers. He was the pioneer of that technique, starting inside the disc, which I do on all my surgeries. I've adopted his technique of inside out. He's one of the true pioneers in the world of endoscopic spine surgery. I owe a lot of what I do to him. I was trained by several endoscopic spine surgeons, and there weren't that many, but he was probably the most influential when it came to lumbar, what we're doing today. He didn't do cervical or thoracic. I had to learn that from the Koreans. Dr. Sang-Ho Lee and Dr. Choi Gun. I don't even know if they practice medicine anymore, if they do surgery anymore. They may not. But they were my mentors as well. Somebody wrote an article this week in Becker's, why is the United States so far behind other countries in endoscopic spine surgery? Great article. It's not very informative, but it just illustrates the fact that the United States is very far behind, and I can tell you why. Number one, it's a very difficult surgery to learn. Number two, the equipment and everything is very expensive. You have to buy it. If you don't have, most hospitals don't have it. And actually, hospitals don't have it, period. I could say that with confidence. Number three, the implant companies don't want surgeons doing this surgery, like I've already said. They're going to lose all the revenue from screws and rods and cages and plates, all that spinal implants and biologics like bone graft, all bye-bye. Overnight, if surgeons knew how to do this surgery overnight, all that revenue would be gone. The United States would literally save billions of dollars in expenses. Billions. billions upon billions upon billions. Because it's not just the cost of the implants, it's not just the cost of the surgeries, but it's also the complications that arise from fusion surgery that are massive. People go to the ICU, they lose their limbs, they lose their bowels, they're sick and die, and they cost the system billions of dollars every year. And all that could be avoided with this surgery you're watching right now, the Deuk laser disc repair. We are done. I'm going to head over to the conference room and answer questions. Like I said, our next surgery is the thoracic. Take this, and let's just see if we can see the nerve root. Barely, right there. You can see a blood vessel on top of it. But let me get this thing right here. Seem to be coming in low today. Just want to make sure this laser on.
Ready.
Let's go, laser on. Laser on. All right, it's okay. Thank you. Here you go. Off. Done. Louise, teach this young lady. Teach this young lady to be successful. All right, so Sean, let's show our audience the incision for this entire surgery so they can be amazed at how small it is. All right?
You can see it.
All right, so let's dry this up, dry this area up. And let's take the tube out. Now I'm going to show you the tube is here. Blood pressure is good. Put some pressure, please.
Yes, sir.
I want to put some pressure on the paraspinous muscles as I take the tube out. I don't want any bleeding. So keep some pressure.
Yes, sir.
Now, if I had done the alternative surgery to this to cure his back pain and leg pain, which I could have done, it's called decompression, reconstruction, and fusion. That's a simple term. And it would involve an incision on his back that would be this long, right here. That's where the incision would be. You see this? How long it is, guys? That's about 10 inches, 11 inches long, right there. So look at our incision. Now, we also would have lost probably 300 mils of blood, which I lose very little compared to other surgeons for a surgery like that, a fusion with osteotomies, reconstruction. Instead, we lost less than 5 milliliters of blood, like literally probably 30 or 40 drops of blood at most. All right, I'm going to come over there and answer questions for you all. Meanwhile, we're going to put a Band-Aid on, because that's all it is, a Band-Aid incision. Keep pressure. I want 4 minutes of pressure. All right, any questions before I head over there?
None currently.
All right, viewers, go ahead and type up your questions for me. Or if you have a topic you want me to talk about, I'll be happy to do that for you. All right, and I'll be there in just a couple of minutes. I got to get myself over to the broadcast room.
testing.
Okay, folks, so I guess we're using the mic, not the camera. This is Dr. Deuk Majan. We just completed a Deuk laser disc repair endoscopic spine surgery on a patient with 3 herniated discs in his lower back. He's had chronic back pain and pain in his legs, mostly on the right side, which is why we did the right side today. And if the patient continues to have pain in the left leg, which I don't think he will, after surgery, then we will come back and do the left side. We've already talked to the patient about that. He's aware of it, and he's prepared to come back and do the left side if it's necessary. I would say there's about a 80 to 90% chance that he's not going to need the left side done. So I think we're going to have nailed the back pain and both leg symptoms, pain down the legs, numbness, tingling, weakness, with this surgery on the right side. What we found when we got in there was that the discs were damaged differently with different age injuries. And the L5S1 disc was probably, the bottom disc was probably the most preserved anatomically. It looked the most normal. But the 4-5 disc and the 3-4 disc were more damaged, with the 4-5 disc being the worst one. Structurally, what I saw with a lot of scar tissue, calcium deposits, ossification, bigger tear, and less nucleus pulsus left in the disc space. So more degenerated disc at L4-5, certainly. That said, it has no bearing, to be honest with you, on the results of the surgery. I've not found that to matter. At this point, I've done about 1,350 surgeries of this type, endoscopic, in in about 16 years. And my average is about 2.5 discs per surgery. And so if you multiply 2.5 times 1,350, you get a pretty big number. It's over 3,000 discs that I've repaired in these 16 years. So it's a lot. And what all that experience gives me is an insight into basically the pathophysiology of disc disease that very few other people in the world can match, because I've done so many disc repairs, and I've seen so many tears and so many herniations, like so many, a lot, that, you know, I can tell you that they're all about 80% the same. However, what the difference is mostly is the overall condition and health of the disc can be different based on how long ago the injury occurred, and how many times the disc was re-injured over the years, how much degeneration the disc had. So structurally, there are big differences in terms of how collapsed a disc is, how much nuclear material is left, how much scar tissue there is. Those are all variables. But the one thing that stands the same with all of them is that the tear itself is the source of the back pain. And it doesn't matter how bad the tear is, how long the tear is, how degenerated the disc is. You repair the tear, the pain goes away. And it's pretty amazing, that consistency. So even in a disease that has a tremendous amount of variation with respect to morphological changes to the disc, you still have tremendous consistency with respect to the amount of pain relief physiologically we get without variation. I mean, honestly, in 1,350 Deuk laser disc repair patients I've treated, we've been able to get rid of 100% of the pain in the discs. Now, people come back, sometimes they'll have aches and pains in their back, but it's not coming from the disc, it's coming from the piriformis muscles, or it's coming from the incision or the inflammation in the muscle, but it comes from something other than the disc. And those things are easy to fix with massage therapy, muscle relaxers, time, basically other treatments for those that are appropriate for those diagnoses. So it's incredible, though, that the actual disc pain is completely gone after the surgery. Do we have any questions? Hope you enjoyed the surgery. We'll be back in about 30 minutes with